didactic session and then some cases, but we're kind of just doing them embedded cases. So hopefully people like that. So as we go along, feel free to think about cases for future topics that if you wanted to share any, if you have any cases that come up. So here's my move this forward. Okay, so the first case we're talking about is um, this was a 15 and a half year old seen a couple of years ago, June of 2023. So I'm just highlighting some of the dates so we can kind of keep track of the timeline. So this was a 15 and a half year old female who came in for an established appointment with Dr. Anzalone. Previous diagnosis of ADHD combined type 1 Jornay 60 milligrams, and her PHQ-9 was moderate at 13 and kind of mild anxiety symptoms. So they said that she's focusing fine in school, but is feeling down due to high level of pressure from sports and school. Grandmother says that this girl has kind of experienced depressive symptoms on and off through middle school, endorsing decreased appetite, fatigue, difficulty sleeping. So, uh, so what additional information do you folks want to know about this kid? People can unmute or put things in the chat. I'll have to find the chat, but you can put things there. Anything? And one of the things I always want to know is, let's see, I guess I have to hit here, is I always want to know the duration of this, because sometimes people just tell you they're having a bad day and so they fill out a form all very negatively because teenagers are often, kind of in the moment. And so they don't do the greatest job with timelines. So, is this just, if this is the summer, right? It was June of 2026. So if she's feeling down about school, presumably this has been going on for a while because there's usually not schoolwork in the summer unless she was busy doing some makeup work, FLVS, or some summer school trying to finish up credits or something. Then she might still be feeling maybe a current stressor. But really, the PHQ-9 is a snapshot of how the person is feeling. I think it says the past week, but the depression criteria are over 2 weeks. So I always want to know about how long have they been feeling like this or how often do they experience downs for us. Some people can say, I have these cycles of downs, they last 2 to 3 days and then they're gone for a month, but every month I have a 2 or 3 day down. So I just kind of like to know the pattern of it. Other questions that people would want to know? Or some of the critical
Has she
things?
has she had any any has she taken any antidepressants in the past aside from the ADHD medication?
Sure. Any prior treatment? That would be great. I see any family history of, let's say, depression. That'd be good to know.
One of the things there's a comment. One of the things I see sometimes in adolescents, I ask them about their periods because pregnancy sometimes can be, they come in with this depressive symptom. And I had one, I remember she was pregnant and she was hiding it from her family. And that was what made her, all of a sudden, she just changed her behavior and it was a pregnancy.
Mhm. Yeah. Yeah. I think so. So were you able to ask that with the family in the room or hard?
Yeah,
We
I
see,
just asked when the last period is,
yeah. Okay.
menses,
Yeah.
and says, well, I haven't had one. And
Yeah.
then
Okay.
it goes into more detail. And,
Okay.
we did urine for, pregnancy test right in the office.
Yeah. It is helpful to ask about menstrual cycles also because of a lot of people have premenstrual dysphoric disorder. So a lot of people, they'll note that their mood is low for a few weeks during a few days during the luteal phase. So they might have a pattern of 3 to 5 days of depressive symptoms that happen, premenstrually. So it is often good to ask about that. And certainly, Natalia is saying stressors. We always want to know if there's anything in particular going on. So she's saying school and sports, but those may be chronic stressors versus something acute that happened. So certainly there's those things. I'm not, you may have put this on the PHQ-9. I'm not sure what she checked, but regarding suicidal thoughts, she said that she's had some thoughts, but doesn't come close to doing anything about that. But she has engaged in some cutting in the past, back in February of 2023. And remember, this was June of 2023, so a couple months prior. So presumably, maybe the depressive symptoms have been there we don't know if they've been there solidly since February, or is it kind of like, again, cycles of some sort? Um, Sometimes that just helps you decide whether you're going to be watching and waiting, or whether you're going to be referring this kid for treatment. Additionally, she reported with the anxiety. When asking about that, she said she had an anxiety attack at school 2 weeks ago, and then she felt like her heart was racing. She zoned out, felt like her heart was racing. That she has anxiety attacks that happen multiple times, and she's usually able to breathe through it. She said about 10 in the past year. And the grandmother says she was previously diagnosed with an anxiety disorder, and the grandmother has had anxiety attacks. So some history of that. So based on those things, what do people think about diagnosis and treatment recommendations?
I'd probably ask a few more questions about stressors, dating, any, substance use. I don't know if we that because the computer wasn't working for a second, and then any excessive highs in the past as well.
Sure. Sure. We want to ask about excessive highs to help make sure we're not thinking of bipolar disorder. I mean, she's had anxiety attacks throughout the past year, and feels like she has anxiety attacks, somewhat. So about 10 in the last year, so maybe a little less than once a month. So Corinna says lab work, CMP, CBC, thyroid, EKG. You could do those things. I mean, they're always a good idea to do those things. And if she's having an anxiety attack once a month, I'm not too concerned about her thyroid, but thyroid can certainly be a concern for depression. So if she's had fatigue, hair loss, weight gain, certainly we would get thyroid. But often I think it makes sense in primary care to go ahead and do that. Also to look for any anemia, in terms of depressive symptoms. But it does sound like she's had mood and anxiety symptoms on and off throughout the past year, and her PHQ-9 is moderate. So I'm seeing Anna Pama say maybe fluoxetine would be something to think about. So let's see. So just by way of review, the criteria for major depression are a depressed mood or anhedonia, which is like not being able to enjoy things, and 4 other symptoms for at least 2 weeks. So those are like the SIGI CAPS is the mnemonic we teach medical students. So the S, that's like, you want to prescribe energy capsules. So for those of us who used to do handwritten prescriptions, the SIG is, take, and that would be 1 energy capsule, SIG ECAPS. So sleep changes, teenagers more often have hypersomnia, but they can also have insomnia. They can have like a decrease in interest, feelings of guilt, worthlessness, hopelessness, decreased energy, concentration is usually decreased changes in appetite, changes in psychomotor activity level, being like really psychomotor retarded, not being able to get out of bed, feeling very heavy, like it's very hard to get up. And then suicidal thoughts or recurrent thoughts of death. Those would be, so depressed mood and loss of interest or inability to enjoy things, plus 4 of these symptoms for at least 2 weeks, which sounds like she has had. So she was diagnosed, she has the ADHD combined type diagnosis, and she was diagnosed with moderate depression, recurrent depressive episodes. So must have been some history that she'd had some depressive episodes in the past, as well as generalized anxiety disorder. So remember, anxiety disorder, GAD, you can diagnose after 1 year of having persistent anxiety and difficulty controlling the worries. So it was recommended that she stay on her Jornay, begin fluoxetine, and lab work was done. At least vitamin D and lipid panel was done. I would agree. If I was getting lab work, I would get the TSH and a CBC for sure, probably a CMP as well. And then they talked about a safety plan for when she has any thoughts about suicide, and there's recommendation for therapy. So, So if we think about the Building Bridges of Understanding pathway for depression, you start off with the PHQ-9, the checklist, and she had she was above the cutoff for moderate depression. So we did more of a focused assessment, asking a few more questions about family history and stressors and how long things have been going on. Here's the cutoff points that, above 10 is a moderate depression, above 15 is moderately severe, and 20 is severe. So she was in this moderate level. So she had moderate depression. So we refer for therapy and consider medications. So that's what was done in this case. And when we think about medications, the two that are FDA approved in her age, it would be fluoxetine, which is FDA approved for ages 8 and above, and escitalopram, ages 12 and above. So you could have used either of these. So usually starting with fluoxetine, since she's, well, I think this age is wrong here. I think this age is supposed to be 11 to 17. Oh, here it is. Okay, so she's over 12. So the starting dose is 10 milligrams. So that's what somebody was recommending. And I think that's what we did for her too, right? Starting her at 10 milligrams and then likely going up to 20 with time. With escitalopram, you might start with 5 and go to 10. So this case tracked right along nicely with the depression care pathway from the Building Bridges of Understanding. Any questions about that? Or thoughts?
A quick question.
Yeah.
A somewhat similar kiddo without the ADHD hit all the criteria for depression, but their PHQ-9 was 4. I didn't quite understand. They had a history of depression in the past, but they said that it didn't. There's a 15-year-old. She said she didn't feel like herself without being on the on medication. So she requested to be on medication again. And I was like, slightly unusual.
Well, here and there you see somebody who tells you they feel fine, but they look terrible. And when you give them a form, they fill it out with the 20 or more. Like some people just, they'll write something down. Now your kid is the opposite direction. Occasionally you see somebody who like doesn't want to say they're that bad. Like, oh, I'm not really that bad. I'm not that bad. But then they'll say, but I really don't feel like myself. So, the screeners are screeners and they can try to help you. They're trying to help with, making sure that, they do have a specificity usually of like in the 90s. So they typically do rule out most cases. But I think if somebody screener is negative, but they're telling you everything that goes with depression, I'd go with what they're telling you, right? And then, we use the screener sometimes more like for the people who have a disconnect where they look terribly depressed, their functioning is awful, but they're telling you, I'm fine, I'm fine, I'm fine, leave me alone. And you can tell that they're not fine because they're failing classes, their behavior's changed. And so the screeners give you some information, but it's not 100% for everybody.
Good, because I treated them.
Yeah. So, yeah. Yeah. So at Healthcare South Florida, they have a really nice safety plan that can be put together electronically, can be printed out for everybody. So I think a lot of you are there. And so, obviously for this kid, they put together a safety plan. So like step 1, warning signs, behave. What is it that tells you a crisis is developing? This is really interesting. A lot of kids don't, cognitive behavioral therapy, is helping people connect the thoughts, feelings, and actions, right? And a lot of teenagers, they know they don't feel good, but they haven't really stopped and tried to think about what's going on. So just filling this out can be really helpful for them. I've had, lots of kids where it's really hard for them to like think, well, what is it? When is it that I tend to get upset? And then when they are able to figure that out, they often can, just knowing that helps them cope with the situation better. Like, oh yeah, this is always a trigger for me. I need to remove myself. So for this kid, it was when my family gets in an argument, when I'm overwhelmed, when I'm thinking about my dad, right? And so then step 2, internal coping strategies, things I can do to take my mind off my problems without contacting another person, which is nice because not everybody else isn't always available. So listen to music, talk to my aunt while I was talking to somebody, but going for a walk or playing basketball, right? So helping them think, what are the things that help me feel better? What would be good in this situation, rather than doing something that's going to make my low mood worse. So is there something that I can do? And what kind of people or social setting is going to help with distraction? So getting in touch with a friend, talking to my aunt, walking around, or going to the basketball court. And who can I ask for help? My brother, my stepmom. So helping them kind of think through this. And then obviously the family can have, presumably the parent also might see this, and the parent might be able to prompt them, like, "Hey, you look like you're having a rough time. Why don't you go out to see what's going on the basketball court?" Or, "Hey, why don't you call your aunt, or talk to your brother right now?" So sometimes the parent can also help prompt them to do things that we know they've identified as positive. And then, of course, the step 5 is you give them professional agencies that they could contact, presumably, the local crisis center, some national numbers, the crisis text hotline, things like that. So, and then there's step 6, something you could do to make your environment more safe if that was necessary. And then one thing that's important to me and worth living for. And so this kid said they want to see what they can bring to the world. They want to be able to play basketball and track. They want to become, get some career goals, right? So that's a nice exercise if you have time to do that. I don't know, Dr. Anzalone, did you do this in the first appointment, or did this get done with somebody else in your office? Dr. Tam did this? Did you crisis consult?
So I was going to just point out that
Yeah.
this is our adaptation of the Stanley and Brown safety plan, and I'll put the general template for it. It's available and free to reproduce and use, and I just popped it in the chat here. And on ours, we have both our local crisis supports as well as 988, so the national text line. But one I'll point out as well, and I'll put the information in the chat. But it's the last one on the second page, Center for Progress and Excellence. This is a mobile crisis response team, and they cover Lee, Collier, Charlotte, Hendry, and Glades counties. And we've had a few patients connect with them and reported good experiences. So just something to keep in mind. And sometimes that's nice because if they can't get in for an immediate appointment or they're waiting for follow-up for therapy, that there's still supports that they can acquire readily if needed.
This is nice. I think I might see if we can make templates of something like this for our electronic record that people could pull up and, have it just pulls together the information nicely. So, and so this was something that Dr. Tamley did with you during an intake or during the appointment, you think?
So this would have been I completed this during a warm handoff. So when when Dr. A encountered the behavioral health concerns, then I went in and talked with the patient. And based on what she reported, then I completed this with her and then prepared it and sort of made that like the first intervention and then followed up with her for therapy and reported everything to Dr. A, who then talked with the grandmother about starting the fluoxetine.
Yeah. And to some extent, you could have a blank form in paper if they're being seen in person where you could ask them to sit in the waiting room and fill this out like before they leave, and turn it in at the desk or something. So, I mean, I guess in terms of time and efficiency, if you don't have a warm handoff at your site or accessible, you might also be able to ask them to work on filling this out because these are nice prompts and questions for the kid and the family to talk about. Okay, so this was a follow-up in August, and the kid was taking the fluoxetine 10, and the grandmother, but unfortunately, the kid had a rotator cuff tear playing basketball and was doing physical therapy. But grandma thought she was handling the stress well from the injury, was feeling better, performing well in school, waking up with more energy, less fatigue. And the vitamin D level was a little bit low in the insufficient range at 27.9, and the triglycerides were slightly elevated, just a notch above. So they were instructed to add a vitamin D supplement and continue things, and also to continue counseling. So, yeah, I don't know whether you guys have any trouble with vitamin D. I have lots of people with commercial insurance that won't authorize a vitamin D when I'm trying to link it to depression. I don't know whether you guys have that trouble at all, but that's a constant frustration that I might want to check it, but I often can't get insurance to approve it. And then labs are kind of ridiculously expensive. It's going to cost you like $90 if it's not covered by their insurance, unless I get them to go to one of the labs that does like self-ordering or self-pay kind of things. So,
Dr. Stock, I'll be totally honest. I'm not sure why that was ordered. I'm imagining that it was probably part of a physical. The kid was probably almost 16. We'll check lipids at around 11 and we'll do it again at
Right.
16. And
Yeah.
then the vitamin D may have been triggered from having a low vitamin D in the past from probably
Perhaps.
whether the kid was overweight and maybe it was part of a workup for obesity and that was part of it. And then just was followed up on. That's probably what that was about. Because typically we don't routinely order vitamin D as part of a screen. So I'm sure
Yeah.
it was probably related to an
Right.
abnormal on the chart. I was just following up on a low level, ensuring that the kids' levels were really low and need medication. So the code I probably used was vitamin D deficiency or insufficiency, and then ordered vitamin D.
And I think
Yeah.
the first visit that this started with a physical, that she was scheduled for a physical, so it could have just been the routine
Yeah,
lab work
yeah,
from.
I think that's what it looks like, Dr. Tim.
Okay. Makes sense.
That sounds like
Yeah.
I'm just predicting my own behavior without even
Mhm.
looking at the chart.
Who better to do
So,
it?
so about a month later, this kid comes back with depression. About a month later, she comes back and she's taking the Jornay 60, the fluoxetine 10, is taking the vitamin D supplement, has some panic attacks, and a general kind of feeling of fear, and has had two panic attacks in the past week, being and feels like maybe I'm going to be a failure, right? So better, but still having some panic attacks. We often talk about a free floating anxiety. So, like, people just have anxiety. And part of what happens for people with anxiety is that their anxiety attaches, we talked about this with before, I think, to whatever's going on. So I'm worried about sports or I'm worried about school, or it finds things to attach to. And at some point, people begin to realize that, you know what? I'm just worrying because I'm worrying. And like in the summer, maybe I don't have sports or school, but I'm worrying about whatever else is going on. And so people often feel justified in their worry because they can list something they're worrying about. But the truth is that they really just have this generalized sense of anxiety that doesn't seem to go away even when a stressor passes. So the tournament ends or the school year ends, and that sense of being tense and on edge just doesn't go away. So any additional information people would want to know? She's having a couple more panic attacks, feeling anxious. Certainly, I always want to know if they're taking the medication. They sometimes neglect to tell you. I try to always ask teenagers, how well are you doing at taking this every day? Because sometimes they're like, oh, I take it at least twice a week, but I forget a lot. That's one of the nice things about fluoxetine. It's got a really long half-life. It's nice for teenagers in that sense because once you build up the level, the half-life is like 5 to 7 days. So like you probably aren't going to even see symptoms worsen until you've been off of it for a couple of weeks. So it's really forgiving for teenagers who maybe forget it if they go on a sleepover or just are intermittently taking it, but still always nice to ask. Are you still taking this? Because sometimes you go through the whole appointment and they tell you they stopped it a month ago, and you're like, we could have led with that. But so is she taking the medicine? Anything else people want to know? So the additional question about sleep, diet, change in routine, she says she's been consuming a lot of energy drinks. So asking about whether she was doing anything different. So drinking a lot of energy drinks. And that each of those panic attacks she had last week were on a day that she had an energy drink. So we would, Dr. DeVera, I guess, I guess Dr. DeVera saw this kid, not Dr. Anzalone, Dr. DeVera said, hey, stop drinking the energy drinks. We'll see how you're feeling. So it's always a good idea.
Thank you, Dr. DeVera, for covering.
Yeah.
I don't even remember that.
I think this is like a cameo appearance that they were, when you were in our office, they were due for a follow-up, but I think Dr. A might have been out. So
yeah. And other people were pointing out that, yeah, we would want to ask if there had been new stressors that was causing the panic attacks. And we might ask about family constellation, if this kid's living with grandmother, sometimes there's like contact with a biological parent, or some change in the family constellation or something that's kind of, anything else on their mind, something else that's concerning them. So, that often can be, it's like sometimes people will say this. Sometimes it's interesting how families will have one thing going on and they'll say that something else is kind of out of the blue, and when you hear it, like they'll be saying, "Oh, they're having panic attacks, and I don't know why," and they're like, "Oh yeah, mom just went to jail." And they're like, "Yeah, but like mom, she doesn't live with mom anyway, so why is that a big deal?" But like for some kids, that is a big deal. So it does help to kind of ask if there was anything else that's changed in terms of like anything that's changed in terms of who's living in the house or any stressors related to family or anything.
You have a threshold for advising hydroxyzine. I think this is good to get rid of the caffeine thing first. But what's your threshold for hydroxyzine?
Pretty low. I mean, hydroxyzine is not that, I mean, the biggest problem with hydroxyzine, I think, is that people can overuse anticholinergics and end up getting more cavities, right? So I tell people you have to make sure you're brushing your teeth. You can be sleepy too. And also, can the kid use it? Like, because if they're having panic attacks at school, you have to like send the bottle of some hydroxyzine to school, labeled, have the kid go up to the office and all of that, which they may or may not be wanting to do because the kid's not supposed to be taking their own medicine, at least at a public school. So so to some extent, I need to know like where are the panic attacks happening? Whether the kid could be, is this 15-year-old, almost 16-year-old, could she be have hydroxyzine in her? Like, is this happening at sports practice after school when she's having the energy drinks and that's when it's happening? And then maybe she can have hydroxyzine with her. So like what adults with her to be able to administer that anyway. So we have to decide whether that would be, appropriate, so to speak, but it can help, really, some people feel like it helps.
Yeah, she sounds competitive, so it'd probably be a little bit different than her personality, would be my guess.
I don't know. I mean, if she's drinking energy drinks, and she may. Some people are really afraid with panic attacks and would be willing to do anything to kind of stop them. So, I think I would probably say I might have said, depending on my availability in the schedule, I might have said, stop drinking the energy drinks. I'm also going to give you hydroxyzine. If you're still having panic attacks when you've been off the caffeine for a week, then you could use this hydroxyzine in its place and um, make an appointment or call because we want to talk about going up on your fluoxetine at that point. So
Dr. Stock, when would you consider increasing the Prozac or fluoxetine?
well, caffeine, you probably could do it within a week, if you know that like she's hasn't had any caffeine and she still had a bunch of panic attacks this week, you could probably do it a week later.
Okay.
Just the question is just like, what do you think the half-life is of caffeine, or when do you think that's going to cause a panic attack? It's usually the same day. So, if she really didn't have any caffeine for a week and still had multiple attacks, I'd increase it.
Right.
But, here we asked for a 1-month follow-up, which is perfectly reasonable as well. And let's see. So a month later, she's going to see Dr. Christian on that day, or that's who was there. And so she's performing well in school. Her appetite's normal. Her mood is stable. She started a job at Chuck E. Cheese. And since she stopped energy drinks, I guess she's not having any panic attacks. I'm not sure if it says that exactly, but no panic attacks. And they feel like stopping the energy drinks, doing the therapy, that's all helped. And the fluoxetine 10 is working well at this point.
So this is an example of everybody doing building bridges where you just hand off one to the provider to another provider to it's consistent, recommendations. Pretty awesome.
Yeah.
It's awesome, guys. Well done.
Yeah. Let's see. Okay, this was in April, April of 2024. So she first came in June of 2023. So in April, she was seeing Dr. DeVera again and said she had discontinued the fluoxetine a month ago. And she was saying she thought she was more sad when taking the medicine and now thinks she's better having stopped the medication, and she's working at Chuck E. Cheese and performing well in school. So it's a little bit unusual, to think you were feeling more sad when taking your medicine.
I think in the case of this, it was maybe just more so she felt like a little bit emotionally blunted, not necessarily sad, but that's what she reported. And then with the increased engagement with the job, it seemed like that became like a really positive influence that increased time out of the house as well as time with peers and friends. So
yeah, that makes sense. And with SSRIs, people can get some blunting. of affect, and some kids over time will not say they don't like that. They don't always use the right word for it. Sometimes they'll say they feel numb or blunted or like they're having a hard time being happy. Like I'm not really sad, but I can't be happy either, like constricted in some sense. Some people do get that. We usually recommend for a first depressed episode. Now she maybe had recurrent, but for a first depressed episode, we usually recommend SSRI treatment for 6 months. So she was feeling better by August. So August, September, October, November, December, January, February, March, April. She'd been on, 6 months of treatment. It'd be okay to take her off of the medication and see how she was doing. And it sounds like her functioning is doing well. So that's fine. Does somebody have a question? Raise a hand.
Dr. Blow had his hand up. You have a question, Dr. Blow?
You just answered it. Thank you.
Oh,
Yeah. So if she truly had recurrent depressive episodes, we often would treat for a year. But um, sometimes it's hard to know retrospectively, like was something really a depressed episode, and even so, we could say, well, we'll see how you're doing. You just kind of monitor for this. And if people stay off of the medication, I usually do a little review with them, like, so what was the first thing? If we think back to this most recent depressed episode, what was the first thing you noticed? Was it changes in your sleep? Was it crying more? Like what was it? And to note that they should know, like, okay, if you begin to have a lot of this again, we should think about whether or not you need to take the medication or whether you need to resume therapy or what else you might need to do in that circumstance. So, all right. So she stayed off the fluoxetine, continued the Jornay and the vitamin D supplement and the counseling. So if we look at her kind of PHQ monitoring, you can kind of see like, this is the PHQ started up here and was down, pretty quickly. Uh, but then went back up and I think and down. I'm trying to remember. I think these were both perhaps is this when they were as increased? I'm forgetting.
I think that was
I,
around the
I think the
time.
GAD-7 was like 17 and the PHQ-9 was like lower, if I remember correctly on that one.
Yeah, I thought it started the
Right.
14 here. Um, but you can see that whatever was happening by October, that things improved and were a good bit better. So like that the anxiety and depressive symptoms were better. She had some improvement, but then her anxiety peaked and we got rid of the caffeine energy drinks and then things were both a good bit better. So if you have the tracking, it is nice to look at those things and see if you can kind of correlate it with the medication changes. So
Dr. Tam, this is a question for you. With depression remission, now this went down. At what point can we get credit for depression remission? How far out do we need to document a negative PHQ-9?
So the UDS rule is that the earliest would be at 10 months. That if you had a PHQ-9 less than 5 at 10 months, that would be remission based on the HRSA standard.
really.
Yeah, so tracking depression remission gets a bit complex, Dr. Stock.
Yeah, because I thought usually it's like 2 months in the DSM-5, but 10 months seems like a lot.
It's a tough
Okay.
that we're continuing to work on.
All right. So let's talk about another case with a few other things. So second case, this is a 14-year-old female coming in for a well child check with her Devera and in 8th grade, history of focal epilepsy on levetiracetam. I can never say that. 500 milligrams. PHQ-9 is moderately severely depressed at 17. GAD-7 moderate at 13. And mom says that kid's having trouble managing anxiety. The patient's always worried. Although the patient says she doesn't feel anxious or worried at all, but and she is performing okay in school. So what other information do we want to know? Mom thinks she's a worrier. Kid doesn't think so. But her scores are pretty elevated.
What are I'm sorry, what were the stressors? If she has any stressors going on in her life, any changes, anything
Right.
happened recently? That's schoolwork, grades, how are the grades?
Okay. She says
She
she's
have
performing well. Performing well in school.
Okay, I'm sorry, that's that. And Yeah, changes physically, like any weight loss, anything physically abnormal with her as far as she's just physically well and she's not losing weight. How's her appetite, sleep pattern? Obviously, we
Yeah.
got that.
Sleeping, it seems sleeping's okay. Yeah, we can certainly go through the depressive symptoms a little more. Eating 3 meals a day, good eating habits, denies drug or alcohol use. So, um, based on her scores, we might be thinking about depression and generalized anxiety. We obviously want to know how long this has been going on. Mom thinks the kid's always worried and always has been a worrier. Um, so let's just move forward for some other things. So
And there was a comment in the chat like
yeah,
about thyroid symptoms are rolling out.
yeah, we definitely would want to know about that. So this anxious character was diagnosis. I don't know. We would typically use 41.9, which is like unspecified anxiety. Um, never used this one, and at least in the private world, you don't get reimbursed for R codes, so I wouldn't use this.
Right. So that's something that I before working in an FQHC, I had really never used many R or Z codes, but I tend to use them in cases like this during warm handoffs as well, because sometimes you do conduct a very brief assessment, and
Mhm.
it depends on the patient. But like in this case, it really wasn't clear. Like mom was insisting the patient's anxious, but the patient was not. So didn't want to go ahead and make true diagnosis with an F code.
Well, but yeah, I guess when I use anxiety unspecified, that is really saying like anxiety is a symptom. So basically, what you want is to have anxiety as a symptom, not as a disorder, right? Just like you can have insomnia as a symptom or insomnia as a disorder. Like, is it primary insomnia or is it insomnia secondary thing? So we would just have to figure out what they like anxiety as a symptom. That would be the better code, whatever that is. And yeah, Cecilia points out we would want to know who answered these questionnaires if they're so elevated and the kid denies. And certainly we might want to know family history. Is she at a strong risk for anything? So, all right. So I just want to be able to get through some of the other points. So at this point, the recommendation was for some of the self-guided toolkits. There was a parent and a teacher toolkit for teacher, parent and child toolkit for anxiety for the teen. So those were given to them, and maybe encourage them to go through those together. And then she would have a behavioral health dual visit in 1 month. So she comes back. Was this in 1 month? Yeah, 1 month later, she comes back in like 6 weeks later in March for this dual visit. And she now says she's been feeling more depressed. She notes that she's had passive suicidal thoughts about 3 days per week. And the suicidal thoughts started when she was in middle school and have been there ever since. And then she also has some overthinking and some panic attacks. So maybe thinking about this with her mom, maybe if they went through some of the questionnaires or thinking about it or them talking about it, maybe she was able to recognize kind of how she's feeling. And actually her PHQ-9 score went up to 19 and her GAD-7 went up a little bit. So what else might we want to know? Let's move through this a little bit. So we want to know, obviously we want to know if she's has a plan to kill herself or active suicidal thoughts. Otherwise, she was diagnosed with major depression, moderate single episode, and generalized anxiety disorder, I guess after further clarification of symptoms. And she was started on fluoxetine. They worked on that safety plan and follow up. So that's what was done. I think you could also have asked her to go through some of the guided self-management depression tools, which are like mood tracking, making time for fun, relaxation skills, thinking traps, and problem solving. So just to kind of review a little bit of that, that there's these, I guess these are the child worksheets rather than the teenage worksheets, but they have these worksheets for, kind of tracking your mood, making time for fun activities, some basic thinking traps. So these could be done with a therapist, but they also could be, done with the parent and teenager together because it seems like them talking about things has helped. So maybe having them do some depression worksheets, some things about deep breathing and progressive muscle relaxation if that wasn't done, or just building positive emotions. So a gratitude journal has been shown to increase positive emotions, where you have people write down each day 3 things they're thankful for, or 3 things that went well. And also loving kindness meditation, doing 10 minutes of that every day has been shown to increase positive emotions. So you certainly could recommend some things in addition to starting the fluoxetine. If we look at, I just want to put these up here next to each other. If you look at the anxiety care pathway and the depression care pathway, so if we went down the anxiety pathway, her GAD-7 being in the moderate range, I guess between moderate and severe, that puts us referring for therapy and considering medicines. Same thing over here with PHQ-9, which is in the moderate to severe category, at least moderate, refer for therapy, consider medicines. Versus, severe, do we need to refer her for specialty care? But really, if you look at the medications for anxiety, fluoxetine, sertraline, escitalopram, those are the medicines to consider for anxiety. And for depression, fluoxetine and escitalopram. So really, we encourage pediatricians to be familiar with those 3 SSRIs, because it's, your kind of moderate level anxiety and depression. The treatment recommendations are in essence the same. An SSRI, one of those 3 SSRIs, and therapy. So just kind of a review of that. And just that the largest study we have to date with teenagers with depression was this TAD study published in 2004. It was 439 adolescents with moderate to severe depression. They were treated either with medicines or with CBT or with placebo or a medicine plus CBT, and they were treated with that for 12 weeks. And the upshot of the study is basically that 71% responded who took the combination of the fluoxetine and the CBT. That's why we recommend the combination medicine and therapy. Those who took the fluoxetine alone, 61% responded. Only 43% who got CBT responded, and only 35% with placebo. So just kind of like, if families are saying, well, what would you do? Combination for moderate depression is probably your best way to go about it. So starting the medicine and approaching therapy if they can. So here's the kind of medication guideline that's in the Boston Children's like information. So again, it's on those small little handouts that for depression, fluoxetine is FDA approved ages 8 and up, escitalopram ages 12 and up. And so being older than 12, we would start fluoxetine at 10 or escitalopram at 5. And usually, in general, you should be seeing a response by 2 weeks, not a full response, but you should be seeing improvement, things going in the right direction within 2 weeks. You don't have to make your follow-up appointments far out. Like I would suggest making your follow-up appointments within a month for when you start a medication, if you can, if that works with your schedule, not waiting for 6 or 8 weeks, but within a month to decide if you're going to go up on the dose. Like if you're seeing some improvement, but not enough, you go up on the dose. If you're seeing no improvement whatsoever, you could go up on the dose, but the data kind of says if you're not seeing some improvement within a couple weeks, they're not likely to respond to that medicine. There are a whole bunch of other antidepressants out there in the world, but most of them have negative studies, negative RCTs. So we really recommend the ones. So it's not like all SSRIs are equal or all antidepressants are equal. We use, so there's no trials with bupropion, and I will say that we use that often for kids who have depression and ADHD symptoms. It does work well, but like mirtazapine, venlafaxine, desvenlafaxine, duloxetine, vilazodone, vortioxetine, they have negative studies. So they're not all the same. Common side effects to look for: nausea and diarrhea. Got lots of serotonin receptors in your gut. So that's why we titrate slowly. We do half the dose for the first, I usually say the first 3 pills, break them in half. So the first 6 days you take half of the dose, then you can go up. And usually any nausea or diarrhea goes away with time, but if it's pretty severe, some people are nauseous all the time on an SSRI and have to change. Often you have a headache, or people can have a headache, and that remits with time. So these are usually less than 20%, but nausea and headache are the biggest thing. In young kids, they can have agitation, impulsivity, activation. That happens in 3 to 8% of patients, where they almost seem like they're full of energy, running around. It's almost like a manic reaction. Some people can have insomnia with the SSRIs, like fluoxetine can cause insomnia if you take it. It's why it's usually a morning medicine. You can have sedation. Some people are tired on Lexapro. And then sexual side effects. So people can have low libido, kind of anorgasmia. So with teenagers, you have to kind of decide what you're talking about with them. You know, when I have teenagers that I know are dating, I may talk to them about how the medication can cause low libido. Some of you may have heard my story that I had one girl on an inpatient unit who, you know, she was dating a guy, her libido dropped. He thought that meant she was cheating on him, and like there'd been like an intimate partner violence situation that had landed her in the emergency room. So like I try to warn girls who are in particular who are dating that if their libido drops, they need to know this could be their medicine and be like, okay, I need to talk to my doctor about this, you know, and often we have to change medications for that. There are some serious side effects. It can increase bleeding time, which is why I usually stop these like a week before surgery. You can get serotonin syndrome based on, you know, other medication interactions, which you see like skin flushing, diarrhea, autonomic instability, muscle tremors, muscle spasms, confusion would be serotonin syndrome. You know, because of that, we don't combine it with St. John's wort or linezolid or MAOIs. You have to be cautious with triptan medicines for migraines because they can cause an increase in serotonin. So can ketorolac and propoxyphene. So, you know, with it can cause drug-drug interactions because most of the SSRIs inhibit the P450 system, slowing down the metabolism of other medicines, and in particular can inhibit the conversion of Tylenol number 3 to morphine. So if somebody's on an SSRI, never give them Tylenol number 3. Not sure if you give it to anybody anymore anyway, but it's not going to be effective because they won't get it converted to the active form for a long time. And citalopram we don't use over 40 milligrams per day because the QTC can get prolonged. So there's just some side effects to know about. 60% of people get a response with the medication with the first SSRI. So that's a number needed to treat of 7 to 10. That's a pretty good number needed to treat. So if response is 50% improvement in symptoms, only 30 to 40% of people actually get into remission with the first medicine trial. And actually, you know, second and third medication trials have lower rates of remission. But the predictor of remission is an early response. So we were looking for that early response. Dr. Halbert, did you have a question or comment?
Yeah, from your prior slide, it was interesting you mentioned stopping it before surgery.
Yeah.
I hadn't really known that was a thing.
Oh yeah. Yeah. Surgeons often want you to.
So
Just it
maybe we
depends on the particular surgery and the risk of bleeding and that kind of thing.
Yeah. Or are the other providers aware of that one?
Yeah, so plate inhibition by SSRI, something you see, but it's rare. I'm not sure how much does it affect bleeding on
I mean,
platelets?
gosh, I don't know. Like I said, it does increase bleeding time because of platelet changes to the platelets. But I mean, sometimes they want you to stop it before surgery. Like I said, if it's a surgery that has a high risk for bleeding or in a small area, then they'll have you stop it, you know, a week or two out. So I think it just depends on how sensitive the surgery is and the person's age and all that. We may not see it, but like older, more elderly patients, somebody who has bleeding problems already, or certainly if they're, you know, so they often have you stop certain supplements before surgeries, you know, because of increased bleeding.
Right.
So.
Yeah, it'd be interesting. I mean, I don't have any family medicine colleagues on.
I mean, I feel like the
Comment on.
dentist. I feel like the dentist. I get requests from dentists all the time, telling
Yeah.
me, is it okay for them to stop their SSRI for a week before wisdom teeth are taken out?
Okay.
You know, I mean, so I don't know. The dentists do it. So, you know, who's going to relapse early? The younger a kid is with depression, the more likely they are to have recurrent depressions. You know, they've had more depressed episodes, they're more likely to have them again. So if they've had more than 2 episodes, we usually stay on the medicine unless there's a really strong reason to get off of it. If they've been more severely depressed or if they've been psychotically depressed, they're more likely to have a relapse again in the future. Okay, so if we go back to this kiddo who didn't really think she was depressed or anxious at first, but she started, let's see. Yeah, so she started the fluoxetine, that's what I thought, it just wasn't listed here. And her PHQ-9 is down to 8 in the mild range, her GAD-7 is down to 6. So they both said she's improved since she got on the fluoxetine 10. Her mood is lighter, she's more outgoing. But she continues to experience SI, I guess passive SI, they're about once a week. So it's less often thinking I don't want to be here, but it's still there. And mom's also concerned that she may meet the criteria for ADHD because she has difficulty with task completion and hyper focuses on certain topics. So what do people think? Or thoughts about that with this 8th grader?
Warm hand up with Dr. Tam and let's evaluate for ADHD. Yeah, I feel like, you got the anxiety under control, if she's still having issues. I mean, it could very well be ADHD because typically it might be unfocused and an inability to focus with anxiety. But once that's under control, there might be an underlying comorbid issue with ADHD.
Yeah, I mean, it could be the case. She's been having struggles since middle school started. So middle school for, a lot of times for girls, they're inattentive with their ADHD.
Right.
So they're not identified by a teacher as being disruptive. They may say they're not putting in their best effort or their best work, but they may or may not look like people just may not notice it, right? So it's pretty common when kids get to middle school that who have ADHD, who have mild ADHD, that we'll see when they get to middle school and they've got multiple different teachers, who aren't prompting them to turn in their homework or whatever, that things fall apart. So we'll see kids who get to middle school and that's when their grades tank, that they may indeed have inattentive ADHD. And I will say, I do see this presentation a lot with teenage girls where they'll come in because of depression or anxiety.
Yeah.
School is a stressor for them, and you're treating the anxiety and depression, and that all gets better. But then everybody's saying, but their school isn't getting better, and now we're really noticing they're having trouble with focusing. So timeline wise, this girl says since 6th grade she's been feeling suicidal. Could be. So yeah, it'd be great if we could get an assessment for ADHD. How easy is that for you guys to do?
Pretty easy, right, Dr. Tam?
Okay.
A lot of our clinicians do it, and yeah, we do that. Oftentimes that's the first concern, and then find depression or anxiety or everything, or sometimes it's one or the other. So
I feel like I pretty often for boys, people come in saying they thinking about ADHD, but for girls, this happens all the time. I've got a girl I'm treating for anxiety, depression, it gets better, but not the school. And then everybody's now talking more, paying attention more, and they'll be like, no, really, this school is the problem, and she can't focus and she can't do her work. Like she's not sad and crying anymore, but she's still sitting there and can't pay attention. So yeah, you could certainly do like here, this was continue fluoxetine, continue the safety plan, and then getting Connor's forms for the teachers and the parents, and then doing an intake with psychology. So okay, so that's great. Some people sometimes it's hard to get an assessment for that. It's great if you guys do. Most people have everybody else have easy access to getting an ADHD evaluation? Look at other sites. Okay. So we can see for her when she started the
there was a
medication.
question in the chat, just should
Yeah.
the fluoxetine be increased if she's still having passive
Yeah.
suicidal ideation?
I probably would actually. You're right, Cecilia. I probably would that she's it's better, but it's not gone, and that's concerning. She is better. She's had a decent response, but yeah, she's not on a high dose at all. So unless she had a side effect that was prohibiting her from going up, like she was having diarrhea or something, or that I would go up to 20 milligrams. Yeah. So because I think that's still an issue. Now that may not fix her focus and maybe she still has comorbid ADHD that hasn't been identified yet, but yeah, I probably would go up. So, all right. And we can see that like definitely she did respond well once she started the medication, her mood, her depression and anxiety both improved. So, all right. So that's all we had for today. Thanks everybody for participating. Please do the post-session feedback survey, and we're going to keep talking about depression in August. So if you've got cases that you can think about that had some interesting depression questions or things that you wanted answered, I think you can submit a case to us, or if you just had specific questions you wanted me to try to cover, please let Dr. Anzalone and Dr. Tam know, and we'll try to cover them. Okay.
Sure, that goes for both our healthcare network participants and external participants. If you have a case you'd like to present, feel free to reach out to me and we'll be happy to include it in the presentation.
Yeah. Yeah. And in the meantime, if you needed question answered, you can always also call the pediatric behavioral health hotline, and that's up here in the corner, and ask myself or one of my colleagues here at USF a question about a case you're seeing.
And you have a call center now that takes takes your name, number, and they get back to you within 24 hours. It's pretty phenomenal. Sometimes same day. Been very helpful in many cases. Absolutely. Thank you, Dr. Stock.
Yeah. Happy to hear from more people.
All right, well, thank you, Dr. Stock, and thank you to everyone who attended, and we'll send out the recording of this, and the feedback link is in the chat, but we'll also send it out after and as well. So, and we'll look forward to seeing some of you at FAC, and then the rest of you in August. All right, well, thank you, everyone.
Thanks.
Good job, guys.